let's discuss about the clinical correlation of brachial plexus. Before that, we shall have a quick revision of previous video because this is the continuation of the brachial plexus. So let's get into that.
About roots C5 to T1, C5, C6, C7, C8, T1. These are all the roots of brachial plexus. C5 and C6 combines to form the upper trunk. C7 forms the middle trunk. C8 T1 combines to form the lower trunk. Each trunk has anterior and posterior division. Each trunk has anterior and posterior divisions. The anterior division of upper and middle trunk combines to form the lateral cord. All posterior divisions combines to form the posterior cord. Anterior division of lower trunk forms the medial cord. Roots, trunks, divisions, cords. Now it's time to learn about branches. Let's pick another color. Okay. Upper trunk. In upper trunk, this C5 nerve root has dorsal scapular nerve. Dorsal scapular nerve. It has C5. It has C5 nerve root. So dorsal scapular nerve has C5 nerve root. And C5, C6, C7 has long thoracic nerve. So the nerve roots are C5, C6, C7. This is also known as nerve of Bell. It supplies the serratus anterior muscle. So long thoracic nerve, C5, C6, C7 nerve root, and it's also known as nerve of Bell. From upper trunk, suprascapular nerve, and the other is nerve to subclavius muscle. So suprascapular nerve, its nerve root is C5, C6. Nerve to subclavius, C5, C6. And one more thing, there are no branches from the division. No branches. So let's move to cords. It's little tricky, but let's solve it. Okay, from lateral cord, lateral pectoral nerve. Lateral pectoral nerve. And musculocutaneous nerve. And the other is lateral root of median nerve. So the nerve roots are C5, C6, C7. C5, C6, C7. For all three, lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. From the posterior cord, upper subscapular nerve, thoracodorsal nerve, lower subscapular nerve. Upper subscapular nerve, thoracodorsal nerve, lower subscapular nerve. And the nerve roots are, other than this, there are two branches from the posterior cord, that is axillary nerve and the radial nerve. Upper subscapular nerve has C5, C6. Lower has the same C5, C6. Thoracodorsal nerve C6, C7, C8. So C5, C6, C5, C6, C6, C7, C8. Axillary nerve has C5, C6. Radial nerve has C5 to T1. That is C5, C6, C7, C8, T1. So these are all the branches from posterior cord. Upper subscapular nerve, thoracodorsal nerve, lower subscapular nerve, axillary nerve, and radial nerve. Now let's move to medial cord. Medial cord has medial pectoral nerve, C8T1 nerve roots, medial cutaneous nerve of arm, median cutaneous nerve of forearm, medial, this is not medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and the nerve roots are, arm has T1 nerve root, the medial cutaneous nerve of forearm has C8T1 as nerve root, and the other are ulnar nerve and median root of median nerve. So this is ulnar nerve, and here is median root of median nerve. Ulnar nerve has C7, C8, D1. Median root of median nerve has C8, D1. So the majority of the branches has C8, D1. Median pectoral nerve, medial cutaneous nerve of forearm, medial root of median nerve has C8, D1 as nerve root. So the different is medial cutaneous nerve of arm has T1. The ulnar nerve has C7, C8, T1. Let's move to the clinical correlations related to brachial plexus. So here, Erb's palsy. Erb's palsy is an injury to upper trunk. Erb's palsy is an injury to upper trunk. So, injury to upper trunk. It has C5, C6 nerve roots. This is due to birth trauma or fall on shoulder. It affects axillary nerve, that supplies deltoid muscle, helps in shoulder abduction. And it also affects musculocutaneous nerve that supplies biceps and brachialis, which helps in flexion of elbow and supination of forearm. So that helps in flexion of elbow and supination of forearm. Here, injury of these two leads to adducted shoulder plus extended and pronated arm. It's also known as Erb's palsy, also known as policeman tip deformity. Or waiter's tip deformity. So this is about Erb's palsy, which is injury to upper trunk, and the nerve root is C5, C6. So the nerve roots which has C5, C6 is affected. You can see here axillary nerve has C5, C6. And musculocutaneous nerve has C5, C6 nerve root. It also affects radial nerve, but the clinical significance is not so visible. These are all the two nerves which is injured, and the features and symptoms are visible. So let's learn what if it affects the lower trunk. So lower trunk injury means to be Klumpke's paralysis. This is Erb's and this is Klumpke's. So let's learn about Klumpke's palsy or Klumpke's paralysis. Clunkies. As you know, it's due to injury of lower trunk C8T1 nerve roots, and it's due to hyperabduction of the arm. And it's due to hyperabduction of arm. It affects lumbricals and interosseous muscles. That helps in flexion of metacarpophalangeal joint plus extension of interphalangeal joint. Injury leads to injury leads to injury leads to extension of metacarpophalangeal joint and flexion of interphalangeal joint. It's also known as complete claw hand. It's also known as complete claw hand.
Klumpke's paralysis is due to the lower trunk injury. The lower trunk injury affects lumbricals and interosseous muscle. The function of lumbricals and interosseous is flexion of the metacarpophalangeal joint and extension of the interphalangeal joint. These are the phalanges, so in between that is interphalangeal joint. So helps in extension of interphalangeal joint and flexion of the metacarpophalangeal joint. But due to lower trunk injury, the two muscles are affected, so that leads to extension of the metacarpophalangeal joint and flexion of the interphalangeal joint. So this is known as complete claw hand. It is also known as complete claw hand. Thank you for watching the video. Our plan is to go step by step. That is, now we are in anatomy, which is upper limb topic, and gradually we will move to other parts. Once this subject is over, we will get into another subject. So for step by step learning, watch our videos, like it, share it and subscribe it. Thank you so much.